Now, what if I were to tell all of you that anxiety is perfectly normal and anxiety is evolutionary adaptive? And I would argue that anxiety is actually a good thing. I would say that anxiety itself is a good thing. If you think about the fight or flight, if there's a saber-toothed tiger chasing you and you're running away and you're anxious, that's probably a very very good thing, right? That you're feeling anxious. Um, or if you're having an exam and you have anxiety, I would also argue that's a good thing. Some anxiety actually helps you do better. If you have no anxiety on exam, I worry about you and you're probably not going to do your best. If you have too much anxiety on an exam, I also worry about you and you probably will not do your best. But I would say that anxiety exists because it is evolutionary. An adaptive emotion that we have. And again, I would say that being anxious is a relatively good thing. Now, when you cross into disorder territory, when it becomes maladaptive, when it becomes excessive, that might constitute a psychiatric disorder. So anxiety itself, I would argue, is not bad. It pushes you to do better at things, but too much and maladaptive can be crippling. Now, if we think about anxieties or anxiety disorders as a whole, anxiety disorders typically include, well, I won't go there yet, but I will say this. Anxiety disorders as a whole show up in the medical setting probably second only to depression and alcohol abuse. So they're one of the most commonly presenting issues in both mental health and medical surgical centers. And there's been some research that shows that anxious patients actually overuse medical service, and they want their primary care physician to address their issues, but in reality, it's kind of like the underlying anxiety that's driving the patient. There's really potentially nothing wrong with them, but they're just kind of overusing the system because they want help with their anxiety, but they're going to their primary care physician. Now, the pathophysiology of most anxiety disorders, at least the way we look at them, at least for the sake of this talk, they're pretty complex. But some things that we do know, that it's linked to abnormal regulation of neurotransmitters, and these should be ones that you've heard before, such as serotonin, GABA, and glutamate. We also know that there's a strong comorbidity with amongst anxiety disorders. And we know that there seems to be a genetic component to it. And since most anxiety disorders are very similar to depression, a lot of the medications we use for depression, we can also use as far as to treat anxiety as well. And I'll talk a little about that in just a few minutes. Now, anxiety disorders, they typically include a number of symptoms. And even though I'm not going to go into depth, with the DSM and how you diagnose them, at least not today, I will talk about some things that are pretty common. You might see trembling. A person might report general nervousness or tension. There might be shortness of breath, diarrhea, hot flashes, feelings of depersonalization, worry, agitation. There might be initial bouts of insomnia. There might be poor concentration. They might report tingling. They might report sweating, tachycardia or rapid heartbeat, frequent urination and dizziness. Now, these are just some of the common symptoms that you could see across the board. Now, before you diagnose anybody with an anxiety disorder, what is something you want to rule out? So you want to make sure that you rule out any kind of underlying physical condition, any underlying medical condition that could be the cause of the anxiety. There could be a tumor. We'll get to alcohol and substance abuse in a minute. Could be cardiac arrhythmia, chronic sinus conditions, Cushing disease, delirium, hypoglycemia, hypothyroidism, parathyroid disease, post-concussion syndrome, seizure disorders. Again, there's a list here that you can look down. But what you want to do at the end of the day is you want to make sure that a person is not, suffering from some underlying medical condition that you need to maybe treat first, right? That maybe that's the underlying cause for the anxiety. The other thing you want to check and look into is you want to see if there's any kind of substance use going on or abuse going on. So you want to see if they are using any amphetamines or other stimulants. Some diet medications were notorious for having, stimulants or amphetamines in them. Appetite suppressors, certain asthma medications, believe it or not, decongestions, cocaine, caffeine, and steroids. Those are all things you want to look into. The other thing that you want to be mindful of is maybe the person is withdrawing from like antidepressants or anxiolytics. So they might be already on anti-anxiety medications and they're not taking them or they're withdrawing from them. If you withdraw, you go cold turkey, that could cause anxiety. Again, it could be another substance of abuse. So you always want to rule out both the underlying medical conditions and maybe any kind of substance that the person is taking. Now, we can categorize anxiety disorders in a number of ways. There's panic disorder, and then there's panic disorder with or without agoraphobia. There's agoraphobia with or without panic disorder. There's generalized anxiety disorder. There's post-traumatic stress disorder. There's obsessive-compulsive disorder, social anxiety disorder, adjustment disorder with anxious mood, and then there's just simple phobias. So I'm going to talk about some of these today, and we'll also talk about how you treat them from a pharmacological perspective. So what potential medications could you prescribe to treat these various disorders? And I think I will start with the most common, which is general anxiety disorder. And that is a lot of researchers believe that, then there's a split camp on this, but some researchers believe that general anxiety disorder is a behavioral condition and should not be treated with medication. Though I would argue, and a lot of other researchers argue, is most people with general anxiety disorder actually respond really, really well to a combination of medication and psychotherapy. So not just psychotherapy, but also psychotherapy and medications. And a lot of the research out there kind of is leaning towards that general anxiety disorder is closely related, is actually more closely related to depression than anxiety. And this is kind of the reason why a lot of the medications used, as I mentioned earlier, to treat major depression are also typically effective for treating various forms of anxiety as well, right? So if you notice, I will list medications off that you might have seen previously that treats depression as well. So benzodiazepines, they were introduced in 1961. They were believed to be safe. And at their peak, there was about 30 million prescriptions in 1979. And originally, they were prescribed to stressed out suburban housewives as a miracle pick-me-up. You're having a rough day, you're having a tough time, have some benzodiazepines. Don't do that, everybody. That's not good. That's not good medicine. But back then, they would tell you that. It was so popular that a band, the Rolling Stones, actually had a song called Mother's Little Helper, and it's all about benzodiazepines. Fun fact for everybody who's playing along at home. But then they realized, there is adverse effects of long-term use. So maybe that's not a good idea, potentially. So the CDC and the APA recommend monitoring patients, taking them long-term, and definitely looking at them every 3 months, right? Watching them closely, looking at their blood levels and such every 3 months. So you want to keep an eye on them. Now, benzodiazepines are used still as an anxiolytic or anti-anxiety medication. So if you hear me say anxiolytic, all I mean is anti-anxiety. You can use benzos to treat panic disorder, social phobia, and general anxiety disorder. It actually works to treat stress, believe it or not, feelings of hopelessness, and feelings of sadness as well. You can use it to help with insomnia and mania. So you could use it in that area. You can also use it as an anticonvulsant, a muscle relaxer. It could be used to treat anterograde or retrograde amnesia and alcohol withdrawal. So benzodiazepines, their receptor site is located on the GABA neuron. And the binding of benzodiazepines facilitates the action of GABA. And GABA is an inhibitory neurotransmitter. So when you bind there, there's an increased rate of chloride ions. They enter the neuron, resulting in neural inhibition or reduced cell firing. So benzos, could reduce seizures, absolutely. But the reason why benzodiazepines can be used to treat alcohol withdrawal is due to where they bind and where alcohol binds. So take a look at this graph. And what you'll notice, or not a graph, I should say, this picture, this beautiful picture that I did not draw. What you'll notice is this is the GABA receptor complex. And what do you see? You see benzos binding here, but you also see alcohol binding here. So the reason why you can treat alcohol withdrawal with benzos is because they both bind to the GABA neuron. So they both bind to the same neuron. So you get cross tolerance. So that's an important thing to note, is there's cross tolerance with benzos and alcohol. So things you want to consider when you think about, any medication, prescribing any medication, or you want to think about metabolism. So how is that drug processed in the body? How long is its half-life? Is it short, intermediate, or long? And any long-term benzodiazepine has an active metabolite in it. For example, diazepam is about 30 to 60 hours. And if you have a variant that has an active metabolite in it, it could be 30 to 100 hours. The other thing you want to consider is drug potency. So how much of the drug is required to produce a given, intensity. And all the benzodiazepines, the potency varies amongst all of them. So like 0.5 milligrams of alazapram. I hate saying that one. Also, I'll just say Xanax. So about 0.5 milligrams of Xanax is about the bioequivalent of 10 milligrams of diazepam in respect to potency. So some medications can be much more potent than others. The other thing you want to think about is elimination, or the speed in which Benzodiazepines are metabolized in the liver, so the hepatic metabolism, and are eliminated through the body through urination. So how long will it stay in the body? The other thing you always think about is what are the side effects and are there any withdrawal symptoms? And side effects to benzodiazepines could be sedation, dizziness, loss of control of body movements, or limited motor coordination. These are all very signs or common signs of benzodiazepines. Withdrawal symptoms from benzos could include mood shifts. So it actually can increase your anxiety levels, could increase irritability. You might have physical reactions such as tremors, shakiness, muscle twitching, sweating, and insomnia. Or you might have even more serious things like tachycardia, hypertension, or hypotension. So all could be very, very similar. There's Xanax. It's FDA approved to treat panic disorder, social phobia. It can be used to treat general anxiety disorder as well as adjustment disorder with anxious mood. There's Librium. It's been indicated for treatment of anxiety and alcohol withdrawal. And because of that cross tolerance, so you could use this benzo to treat alcohol withdrawal. There's Klonopin. That's FDA approved as an anticonvulsant. You can also use it to treat panic disorder, social phobia, general anxiety disorder as well. You could also use it to treat acute mania, by the way. I think somebody mentioned mania earlier. You could use it to treat acute mania. And then there is Valium. You could use Valium to treat anxiety and alcohol withdrawal. And I would say typically there's a bunch of medications you could use. One of the most common is the SSRIs that you could use, like Prozac, Lexapro, Paxil. Those might be popular names you've heard. So there you got options when you're treating a general anxiety disorder. You might need to do a sleep aid as well, especially for the short term. So you might need to use Ambien or Lunesta or Sonata. Again, there's a bunch of different drugs you could use, but any of these medications that I have here up on the screen could potentially work to treat general anxiety disorder. The other question I get sometimes is, what are the medications to treat post-traumatic stress disorder? Historically, doctors have prescribed benzodiazepines and neuroleptics, or antipsychotics, by the way, if you hear that word. Specifically, it's atypical antipsychotics, also known as neuroleptics. They've been used to treat patients with post-traumatic stress disorder, especially those who have demonstrated psychotic behaviors. There's been some success with SSRIs and SPARIs. So that's the selective serotonin reuptake inhibitors and the serotonin partial agonist reuptake inhibitors. Other things that they're looking at is MDMA and ketamine, but I know there's more research needs to be done and it's controversial, but that is maybe something down the future pipeline. The other thing that you could treat is obsessive-compulsive disorder. Now, psychotherapy alone has not been shown to be very effective for treating obsessive-compulsive disorder, right? So, you might there's different variations, right? Like cognitive behavioral therapy. It's usually, though, you want to combine them. So you want to maybe combine some cognitive-based approach with a medication that usually has the best outcome. We are not sure on the cause of OCD. We know that it's genetic, so we know there's a familial link that runs in your family. We see that patients with OCD typically have a close relative who also has OCD, or an OCD co-occurring with a tic disorder. So you see that genetic component. And we think that maybe there's a dysfunction in the cortical. I always hate these words. The cortical striatal pathways. That was a tough one. So we definitely see a dysfunction in the cortical striatal pathways. I'll work on that one. Anyway, questions, comments. So when I say that, by the way, I'll be a little more specific. So we see like a dysfunction in the frontal cortex, the cingulate cortex, the caudate nucleus. Some researchers actually believe that childhood infections may contribute to the development of OCD, but more research needs to be done. And when I talk about pediatrics, psychology in the future, I can go into how potentially maybe it arises out of perfectionism in children as well, but that's a whole nother conversation for a different day. So how do we treat OCD? Usually it's with SSRIs or SPARIs, so things that I mentioned earlier. But sometimes the obsessions are severely intrusive and the patient might complain of racing thoughts and insomnia, and then usually you need to give a low dose of an atypical neuroleptic, like Risperdal might work. And again, OCD is that obsessive-compulsive disorder where the patient reports having obsessive thoughts and then compulsions to do things. They might have to check the door handle 7 times before they leave the house. They know it's irrational, but by completing that act, it kind of releases the anxiety, and that cycle kind of continues. So the biggest question is, how do we treat it? Usually with through medication and through psychotherapy. But those are the $1 million questions: is how do we treat it? Now, social anxiety disorder or social phobia is very common. It shows up in both private practices and public clinics. Sometimes patients with social anxiety turn to alcohol. That relieves their symptoms. But sometimes you get an obvious alcohol dysfunction in social situations. So sometimes people start drinking to kind of relieve their social anxiety. So if that could be an issue. And if they start drinking a lot, this could lead to a dysfunction in their social or their work life. Could lead to alcohol dependence. And if they go into their primary care physician will usually prescribe them a benzodiazepine to help manage it. Or you could even use the benzodiazepine for a socially phobic patient. And the problem is with just giving somebody like a benzodiazepine, it allieves the patient's anxiety, but it doesn't help them understand their anxiety. So you can give them the medication to make it so they don't feel it anymore per se, but they don't understand it. You could also use SSRIs, MAOIs, tricyclics, as I said, benzodiazepines. Any ones on this list here you could use as well. Then we have panic disorder. So a lot of patients might come in and believe that, they have a lot of anxiety. They might not recognize that they have panic disorder. They, might complain of having a heart attack or feeling like they're having a heart attack. And really what's happening is the brain is perceiving a threat that doesn't exist. So that fight or flight system kicks on. The brain's, processing all this. Their heart races, their pupils dilate, they have shortness of breath. But there's a mismatch between kind of what's going on in the environment and what's going on in their mind, in their brain. We know that panic disorder runs in families. We know it's biological in nature. Usually benzodiazepines are actually the drug of choice as quick relief to manage those panic symptoms. But once you have those panic symptoms under control, you might want to switch them to an antidepressant, one that works on increasing serotonin to kind of help regulate that limbic system. Because what's happening is that limbic system is on a high alert, right? It's like red alert. It's like there's something happening, right? So the limbic system sends signals to the hypothalamus, the locus coeruleus, and they turn signals to the pituitary. Excuse me, I had to sneeze. So they send signals to the. So once again, I'll start over. So the fight or flight system's triggered. You have physiological reactions. The limbic system sends signals to the hypothalamus, to the locus coeruleus. They send signals to the pituitary, to the thyroid, in the adrenal cortex. As a result of all this, various hormones such as cortisol, adrenaline are produced, and they're readying the body for attack. But with panic disorder, there is no attack. It's a false alarm. And we look at the dysregulation of the limbic system. Specifically, we look at the depletion of serotonin, the excess of glutamate, and the insufficient amounts of GABA. That's what we think might be causing the panic disorder. Not 100% sure, but that's kind of where the research is leading us. And as you could think about, if you're in a panic state and you're under a lot of stress and anxiety, this could definitely weaken your immune system. It could increase your blood pressure, and it could lead to various, cardiac problems. It could lead to cancer. It could lead to a whole host of negative health effects. Anyway, well, that's it for this video. Please like, subscribe, and share, and I'll see you in the next one. Take care. Bye for now.